Good evening, everyone. We welcome you all to OrthoTv original webinar series. Today, we have a very interesting topic, which is the need of the hour. We are all going to talk on the role of vitamin D3, whether it is compulsory to take it or whether it is there any evidence to it. We are going to have three different views on a special type of vitamin called Sunbless 60K. This webinar is brought to you by Zydus, the makers of Sunbless 60K, Nucoxia, Decadurabolin, and OCID QRS. So, without wasting any further time, I hand over the proceedings to the first speaker, Dr. Agnivesh Tikku. Dr. Agnivesh Tikku is a spine surgeon, consultant spine surgeon in Apollo Hospital, Navi Mumbai. So, over to Dr. Agnivesh.
Thank you very much, Dr. Neeraj, and thank you, Ram sir, and thank you, Dr. Salim Patel, for making me part of this event. So, I will be speaking today on vitamin D, why, how, and what to do about it. All right. So, can you see my screen?
Yes. Go ahead.
Okay, thank you. So, vitamin D, it's a well-known fact that vitamin D was realized even before it was discovered that there is a role of sunlight in prevention of rickets. Even people who were exposed to certain radiations, it was found that they developed their bone quality improved. Nobody knew why it was, but still there was some protective role of sunlight and radiation in prevention of bone diseases, namely rickets. Irradiation of UV foods with UV rays was noted to have anti-rachitic properties. This was discovered in 1924. And then the molecule was first isolated by Angus, which was then named as calciferol. So what is vitamin D? It is actually a fat-soluble vitamin, to keep it simple. And it is described in two forms, which is vitamin D2 and vitamin D3. Vitamin D, it gets converted from cholesterol or the fat under the skin. 7-dehydrocholesterol is activated to form 25-hydroxycholecalciferol in liver, which is then further changed to 125-dihydroxycholecalciferol, or what we know as calcitriol, in kidney by hydroxylation at number 1. There is also a second metabolite, which is 24,25-dihydroxycholecalciferol, which is formed. We do not clearly know what is its significance, but probably it has some regulatory mechanism. And whenever there is excess of 125-dihydroxycholecalciferol, the excess of 25-hydroxycholecalciferol is converted into 24,25-dihydroxycholecalciferol. So together, vitamin D2 and D3, they form the sunshine vitamins and also are called as provitamins because they are the precursors to the active form of the vitamins. So vitamin D2 is also called as ergocalciferol. It is formed from ergosterol, found mainly in plants, certain mushrooms, and it has got same molecular structure as D3, but has some molecular changes with additional methyl group and a double bond. But it is less active than vitamin D3. So vitamin D3, also called as cholecalciferol, as we discussed, it converts from sunlight from 7-dehydrocholesterol in dermis and epidermis. Now, as much as I like my favorite singer, Michael Jackson, and as much as I like his song Black or White, but it does play a role. The skin color does play a role in vitamin D synthesis. So dark skinned people they need more sunlight, they need more UV rays as compared to white skinned people for converting this 7-dehydrocholesterol to vitamin D. So what are the functions of calcitriol? And these are with respect to the calcium metabolism. So calcitriol in intestines, it leads to transcription, and then it translates into a calcium binding protein, which mobilizes calcium from intestines. On kidneys, it decreases the excretion of calcium phosphorus and also promotes the reabsorption. And in bone, it leads to deposition of calcium phosphate. So what triggers these hormones and this mechanism? So if the calcium drops, then there is a sudden surge in PTH, which stimulates osteoclasts to increase the bone resorption so that the blood calcium can rise. And it also increases the 1-hydroxylation of 25-hydroxycholecalciferol, or activates the vitamin D. Decrease in phosphorus directly increases or triggers the hydroxylation of 25-hydroxycholecalciferol. So as we can see from here, phosphorus has a direct impact on hydroxylation and activating the vitamin D, whereas calcium indirectly does it through PTH. There has been a bit of discussion that is vitamin D a hormone? It's classically a vitamin, but it functions like a hormone because it is synthesized in skin, synthesized somewhere inside the body. The other vitamins, most of them are not. It has specific target organs. Its action is similar to steroid hormones. It causes a transcription, a translation. It goes to the DNA. It vitamin. And we know that actinomycin D, which inhibits transcription, also decreases the effect of vitamin D. And it has a self-regulatory mechanism. Whenever there is excess, it stops its conversion or activation process. So what is the recommended dietary allowance? An adult male, it is said to be equivalent to 200 to 400 international units. This is what was given in textbooks and we have all been reading, but we will come to that in a bit. In children, the requirement is higher because the bones are growing. In smaller children, they need around 400 to 1000. In older children, they need around 600 to 1000. And elderly people, their requirement is much higher as compared to the normal population. So what are the sources of vitamin D apart from sunlight? So fish has been classically said to have a good source. We can see salmon can, which is not very common in Mumbai, India, only one variety is there. It can give you good 526 to 928 international units. Cod liver oil, which is also available as capsules over the shelves, it gives you around 448 per teaspoon. Mushrooms, they need to be irradiated with UV light so that they can form the vitamin D. And that is usually around 130, 450 international units per 100 gram. Certain process of irradiation have been believed to cause to increase this to even 2000 per 100 grams. But that is a specific process. It's not a regular thing. Egg yolk, which is a regular egg, it per yolk, it contains around 37 international units, which is very less. So does cooking habit affect vitamin D? So let's see what happens if we try to bake the egg in an oven, or we try to fry, or we try to boil it. As we can see, the prolonged heat, like in oven for 40 minutes, decreases it quite significantly, whereas a quick heating, it retains the vitamin D. So it is a bit heat sensitive, especially if it's exposed to heat for a long time. A bit of difference in food quality as well. Vitamin D3 is retained somewhat less as compared to vitamin D2 in baking process. And again, wheat bread is retains more of vitamin D in baking than a rye bread. Two other cooking habits affect vitamin D. Let's see what happens. So in sunflower oil, plain sunflower oil, when you sort of use it in oven, or you use pan frying at high level, you use microwave at high power, you can see all of this, it leads to significant drop in reduction of vitamin D as compared to if you're baking in oven in low temperature, you can see it is better. If you're steam cooking or microwave cooking a fish, here they have taken rainbow trout, it leads to significant preservation of vitamin D. Again, you can see that if you process the food, like in this case, mushroom at very high temperature, it's a very high frying, it's very high boiling for long term, it leads to a loss of vitamin D, whereas low heat, it preserves vitamin D. So cooking habits, we in India, we tend to fry things a lot, whereas in Western countries, they try to smoke or bake things a lot. So this also leads to difference in vitamin D retention in the food, whatever low quantity we get it. Now, coming to the main point, sunlight, how much is sufficient? It's very difficult to sort of quantify how much is sufficient, but there is a difference. There is a huge regional and skin color variations. It is said that in winters, if you're above 37 degrees, 37 degrees above the equator, then virtually you will not get any ultraviolet B light because of the obliquity of the sun. So there is something called as angle of zenith, which was described which is the angle of the sun sustained with respect to the perpendicular. So as the angle of zenith increases, the obliquity of sun rays increase and less of UVB is present in the atmosphere. So it does not go down to your skin, nothing gets converted. So the main aim of having sunlight is to prevent sunburns. Fair-skinned people and certain people are very sensitive, so the aim is to prevent sunburns. So in a good sunlight, around 10 to 15 minutes or so of unprotected sun, to your exposed to your arms, legs, abdomen, and back is enough for making vitamin D for one day. But again, it's a regional variation. Someone may get sunburn in just 5 minutes of exposure, whereas certain people may not. And it is generally said that if your shadow is longer than your body height, you can't make any vitamin D. So the sun needs to be quite strong enough. But again, there are regional variations. This may be true in Western countries, but in India, if the sun is in that position, we talk about testing two things. One is the original serum 25 hydroxy vitamin D, and the other is 125 dihydroxy cholecalciferol or the calcitriol. So whenever we test the 25 hydroxy vitamin D or the total vitamin D, which is the sum of 25 hydroxy D2 and 25 hydroxy D3. Why do not we check calcitriol? It is because it is present in very small quantities and it has a short half-life. It is very tightly regulated by PTH. So if you take a sample in the morning and evening, you may find significant variation, and that may not necessarily represent the stores of the vitamin D. So there is no clear-cut sort of normal value for vitamin D, but what is described is optimal level of vitamin D. So the optimal level is around 30 to 100 nanograms per ml, and 20 to 30 nanograms per ml is labeled as insufficiency, and less than 20 is labeled as deficiency. So how do we manage the deficiency of vitamin D? There are two major concerns in this, or two major factors in this. One is the injectable versus oral. The second is weekly supplementation versus one-time dosage. So injectable preparation is a oil-based. It is equivalent to 6 lakhs international units. It's given as a single intramuscular administration. Many people off the label give it orally, but it's not recommended, and there are no studies to substantiate whether it leads to absorption or whether they lead to normalization of values or not. Oral preparations, they come as liquid, or they come as capsules, or they come as granules. Usually they are 60,000 international units. There are also small amounts of vitamin D which are present in calcium tablets, which may range from various sort of tablets from 100 international units to 2000 international units. Now the question arises that is injectable better than the oral? Now we have this study done in July 2013, in which you can see the graph here. This square represents vitamin D3 and dotted is oral. So you can see in oral, the peak of the vitamin D normalization is achieved much, much earlier than in the intramuscular form. Whereas if you also see the intramuscular preparations, they lead to sustained vitamin D later on in the long term, whereas oral preparation, a single dose, then starts dropping after its initial peak. So another study which compared that if you give intramuscular versus orally over 3 months. So 3 lakhs international units were given intramuscular as single dose versus same amount which was distributed orally over 3 months. So improvement with oral was statistically better at 3 months. At 6 months, oral was still better, which means the vitamin D level measurable in blood were better than the injectable, but it was not significantly better statistically. And despite both oral as well as injectable, 50% did not achieve significant improvement in their vitamin D level. So we need to be very careful. Whatever you are giving is not a sure shot. We have to recheck it and be sure that it has normalized. Another study which came from Gupta and Dr. Mittal, we can see this is comparing 3 lakhs international units intramuscular versus 60,000 weekly for 5 weeks. You can see in this graph the injection, and they have compared that at 6 weeks both achieve the values which are symmetrical, but then oral starts dropping and injection still keeps on rising. So they have suggested that injection leads to better vitamin D levels at 12 weeks rather than oral supplementation. Another question which is asked is that if we give how many weekly doses, some prescribe 4, some prescribe 6, 8, 10, 12. There is no clear-cut guideline. This needs to be titrated person to person. Usually what we follow in our clinical practice is that if it's between 20 to 30, we give 6 doses. If it's 10 to 20, we give 8, 5 to 10, we give 10 doses weekly, all of these weekly, and less than 5 nanograms per ml, we give 12 weekly doses and then continue it monthly maintenance dose. But all of this needs to be reconfirmed at 3 months with a vitamin D level. Another question which we may ask is that when should we take oral supplementation? Is it morning, evening, night? So it is believed that morning it is better because of 2 reasons. One, that we are supposed to form vitamin D from sunlight, and it will happen during the daytime, so it's more physiological to take it during the day. Second is that if you take vitamin D at night, it's believed in some people it can affect the sleep by affecting melatonin, and it can trigger off your circadian rhythm, and then you may not be able to sleep well. And third is that presence of fats improves absorption for 32%. So it may be good to take it with, say, a glass of milk or some fatty substance to improve the absorption of vitamin D. But is taking a weekly dose enough? Content of commercial preparations available in India. Now, all of these were marked with the same amount of drug, but look at here, the variation is from minus 91% to plus 65%, which means if it was 60,000, the actual drug did not contain even 6,000 international units of vitamin D. And some may be even overdosing, like they may have plus 65,000, which may be over 80,000 or even 90,000 international units on a labeled of 60,000 international units. So we need to be very careful with the medicines as well. Despite of all this, why should we prefer oral? The answer is that it is better because it's a gradual replenishment. You don't sort of load the systems altogether, and you don't want to do it unless patient is clinically in hypocalcemia. The chances of toxicity are even less with orals, even if it is believed that 10,000 international units daily dosage has been given to the patient, they do not develop toxicity. I had a couple of patients who were prescribed 8 weeks, and they come after 6 months, and then they say that we have been continuing to take the weekly dose. And when we check, it rarely has been seen that it is never in the toxicity range. And as per the studies, it helps in achieving the quicker peak as well. So when should we prefer injectable? If that is, if it's a malabsorption syndrome, bariatric surgery also affects the absorption of vitamin D, fat malabsorption syndrome, certain drugs like anticonvulsants or antiretroviral therapy, the people who are on drugs because of HIV and AIDS. So that increases the catabolism of vitamin D. And certain other disorders like sarcoidosis, all these preferably injectable are better because they increase the catabolism of vitamin D. So you need to give them a better drug. Again, a very pertinent question, very important question, how many injections? or more often than not, we see people prescribing 6 injections, 3 injections given at weekly intervals, or even alternate day also. I think this is not supported by literature, and it can lead to serious problems because of the hypervitaminosis D, and it should not be done. Even textbook says that one injection is good enough for 6 months or even up to a year, but we need to titrate the doses. We need to recheck before sort of supplementing with more injections or even oral also. Even combining injections and oral, it does not make any sense. We should choose either one and then follow the reports at 3 months. After we have attained the normal value, it is very essential to continue the maintenance therapy. In our population, we have seen that unless you give them around 1,000 international units daily, they do not maintain the vitamin D levels. It drops again. Probably it has got something to do with our darker skin, less sunlight exposure, but we need to give this maintenance therapy. Or you can prefer to give them at 60,000 international units monthly as well. Recheck it at 3 months, and then 6 to 12 months, and then maybe yearly. But we should keep a strict check, and giving a one-time 8-week therapy or 10-week therapy is not enough. We should sort of check them again. And if the deficiency persists, then we should suspect non-compliance or malabsorption syndrome. A very, very important point is about activated vitamin D, calcitriol or alpha calcidol, which is seen in many pharmaceutical preparations. This is an activated form of vitamin D. It is not normally recommended to give this activated because it is uncontrolled. What cholecalciferol you give, it will get auto-regulated, and as body needs, it will convert it to activated active vitamin D. But this is activated vitamin D. It will directly lead to absorption of calcium, phosphorus, raise the blood calcium levels, and it has got very specific indications. Like if the kidneys, if patient has a kidney problem, a CKD, then kidney cannot do the hydroxylation of vitamin D into activated form. So you need to give activated in that. It's also used to suppress PTH when it is very, very high, especially in renal osteodystrophy, because that again leads to bone loss. You can use it to treat acute hypocalcemia because of severe hypovitaminosis D till the time vitamin D levels start rising and they can take over. And essential again is that we should not be using bisphosphonates or denosumab in vitamin D deficiency. If you have used and patient is going into hypocalcemia, then this drug calcitriol comes to your rescue, but it is not meant for immediate use. Toxicity is believed to be more than 100 nanograms per level. Sometimes we get a report which just says that vitamin D more than 150 nanogram per ml. Is it enough? So we had a medical doctor who was given 4 injections, and at 2 months, 2.5 months, she presented with various symptoms, including bone pains and hair loss. And then when the vitamin D was checked, it was more than 150 nanogram per ml. The lab was uh, kind enough that they did the serial dilutions, and when they did the serial dilutions, it was found that the actual vitamin D level was 400 nanograms per ml. So more than 150 can mean anything. So we have to be very careful and watch for hypercalcemia symptoms in these patients, because that can lead to drowsiness, it can lead to lethargy, it can lead to many problems. Kidney stones are one very common. You give 6 injections to a patient and the patient may land up with a urologist 4 months down the line with a kidney stone. It leads to metastatic calcifications. The heart vessels may get calcified, and then later on patient is at risk of developing a cardiovascular disease. And excessive vitamin D can also lead to increased bone loss. So to summarize, uh, I would like to conclude by saying that vitamin D deficiency is widely prevalent and can have serious consequences. It is very, very essential to optimize the treatment of vitamin D. There is no sort of single dosage regime for that. You need to optimize and understand requirements for each patient and give calcium supplements along with the therapy initially, because the bone is deficient in calcium. It needs additional calcium to sort of replenish, which needs to be going from the gut. And follow-up maintenance is very important. We need to recheck whether vitamin D has normalized or not, and then maybe once a year check is good enough to keep it under control. and avoid toxicity. Do not give multiple injections, because it is even more harmful to have a patient with vitamin D toxicity, because there is no treatment as such. It's all symptomatic. There's nothing what you can do except for waiting for the vitamin D to get washed away slowly over a period of time. Thank you very much.
Thank you. Thank you, Dr. Agnivesh. Now we go to Dr. Ram Chadda. Dr. Ram Chadda is a senior spine surgeon in Mumbai. He is the past president of Association of Spine Surgeons of India and also of Bombay Orthopaedic Society. He is the organizing secretary of IOCON 2020. So he's going to talk of his immense experience of the last 3 decades of use of vitamin D3 in spine patients. So over to Dr. Ram Chadda, sir.
Good evening, everybody. Thank you very much, Zaidas, Dr. Salim Patel, Dr. Neeraj Bijlani, and following an excellent presentation by Dr. Agnivesh Tikku, who has made it so very, very clear that my job is now not much to share evidence, but to share my experience. I've been using vitamin D3 for almost 3 decades now. The evidence is now appearing. The experience I have gained from my mistakes, and combining the two, I share what I call a mid-path of expertise. I'll walk you through situations which remind me that vitamin D is very essential. It also at times make me wonder whether it's just a vitamin or a hormone, and actually tell me that it is an essential evidence-based part of good health of our bone and joints. Almost 70% of patients who come to spine specialists and more than 50% of patients who come to orthopedic surgeons, and probably the same number of patients who come to family physicians, have back and neck pain. They are in a situation where they need treatment and we need a diagnosis as well. We go through our usual routine of evaluating them clinically, at times getting their X-rays and MRIs done, and unfortunately label them retrospectively as non-specific back and neck pain because we found no signs, no neurology, normal looking X-rays, and at times normal looking MRIs. What I tend to do, and I've learned from my mistakes, is that I primarily rule out a deficiency of the essential vitamin, which is vitamin D3. In fact, all my men folk who come to me are subjected to a vitamin D3, vitamin B12, HbA1c for sugar, serum uric acid, and possibly an HLA-B27 if I suspect ankylosing spondylitis. And the ladies, the same D3, B12, HbA1c, serum uric acid, and probably an RA factor or an anti-CCP. What I have learned and I share with you, that most of our patients who have nothing on examination and probably nothing on the expensive imaging are vitamin D deficient. Vitamin D deficiency and insufficiency can cause or worsen neck and back pain and muscle spasm. The correction of the deficiency plays an important role in treatment of chronic neck and back pain and spasm among patients who have concurrent vitamin D deficiency or insufficiency, and it can be treated and prevented easily. Please understand, if you were to screen them earlier, it would in many ways reduce the healthcare expenditure which they would need to undergo for the expensive investigations, which then turn out to be normal. Moving to the next most common situation, which is degenerative lumbar disc disease. The same lady, pre and post-menopausal, has lost height, has a slight stoop. Most of us would say this is only because of osteoporosis. Well, probably many of us are right. But then, do we realize that there is something else also happening? Vitamin D status may affect spinal degenerative disease, back pain in older women. Severe deficiency was found to be associated with lumbar degenerative disc disease and low back pain in postmenopausal women. If you are to really read in between the lines, there is an association between lumbar degenerative disc disease, severity, and vitamin D concentrations. Statistical analysis revealed L1, L2 to L5S1 patients with severe vitamin deficiency had more severe disc degeneration compared with those with insufficiency, deficiency, or normal. That means those who had more severe chronic deficiencies had more degeneration of the lower back. Let's look at yet another situation, and you would say, what's wrong with me today that I am talking of tuberculosis of the spine in a vitamin D session? Well, this is what I learned, and this is what I looked for, and this is what I shared. Vitamin D status in pediatric osteoarticular tuberculosis. Ladies and gentlemen, vitamin D has long been implicated to play an important role in immune system regulating TB. Activation of vitamin D receptor by active form of vitamin D, 125-dihydroxy, influences cytokine secretion, suppresses effector T cell activation, and promotes regulatory T cells. Active vitamin D can potentiate phagocytic activity of macrophage and increase activity of natural killer cells. What does this mean? Well, vitamin D leads to expression of an enzyme called the cathelicidin enzyme, which is a microbicidal peptide for Mycobacterium tuberculosis. Insufficiency of vitamin D impairs the first line defense system of macrophages, initiated immune response against TB. So lo and behold, vitamin D may have a role in tuberculous etiopathogenesis, and TB patients have lower vitamin D concentration demonstrated not just in the pediatric but also in the adult population. Now I move a step further. I take you to the seronegative spondyloarthropathy or ankylosing spondylitis. Vitamin D deficiency and subclinical osteomalacia in axial spondyloarthropathy. Very interesting. Axial spondyloarthropathy patients have significantly decreased vitamin D and raised serum alkaline phosphatase. 74% of axial spondyloarthropathies had vitamin D deficiency. Vitamin D was inversely related but positively related to the daily sunlight exposure and calcium intake. In conclusion, vitamin D deficiency or insufficiency is almost 74% in axial spondyloarthropathy. They exhibit significantly lower vitamin D and raised alkaline phosphatase levels with significantly higher bone turnover markers like CTX and osteocalcin, and a low BMD as compared to controls, which gives them subclinical osteomalacia biochemically and is associated in most spondyloarthropathies. Now I'm stretching it further, pushing the envelope to a level where you may probably find it unimaginable. Adult, no. Adolescent idiopathic scoliosis or deformities. The role of vitamin D in pathogenesis of the same. Literature review has demonstrated an association between vitamin D status and BMD, MENARC, and other hormones. Low vitamin D is correlated with the Cobb angle. Relationship between vitamin D and AIS may not be casual which means there may be some correlation. There is a possibility it may be in some way responsible for etiopathogenesis of AIS, adolescent idiopathic scoliosis, and whether vitamin D is in any way related to teethering of the nerve roots and postural control dysfunctions, which is observed in certain patients of AIS, is still under study. Longitudinal studies may be required to examine the effects of fat-restricted diets, which are now being commonly used as a form of dieting even in the youngsters, as well as vitamin D supplementation and vitamin K2 supplementation on the progression and management of scoliosis curves. And now coming to that part which most of us know, osteoporosis, osteomalacia, and rickets. Well, we all know that osteoporosis and osteomalacia affect us either as we are growing old or really grown old. Osteoporosis leads to weak and brittle bones, while osteomalacia leads to bones which become softer. The difference between the two is osteoporosis is where a simple fall from a standing position in a healthy person otherwise can give rise to a fracture because of the brittleness of the bone. While in osteomalacia, it becomes like clay, the plasticine we used to play with during childhood, which is soft and can also break. As children, it was rickets, and as we grow older and still have soft bones, it's called osteomalacia. All these are related to a vitamin D deficiency, and we need vitamin D. It's approved for osteoporosis. Coming to cancer, you would say now Ram is stretching it too long and too far. Well, there is lab and animal evidence that vitamin D status could affect cancer risk. Vitamin D is supposedly shown to have a preventive role in colon cancer. There is study of prostate and breast cancers getting affected to a certain extent, though still not evidence-based. And there is another study where hypervitaminosis D3 may actually increase the risk of pancreatic cancer. So on both ends, we have to be extremely careful. So 5 ways to prevent colon cancer. Number 4 is vitamin D3. They suggest 50,000 IU per week. That's because in our country, we get 60,000 international units. Overseas, it's usually 50,000 international units, which is available. There's also a role that vitamin D supposedly has in prevention in type 1, type 2 diabetes, hypertension, glucose intolerance, multiple sclerosis, and multiple other medical diseases. Does that mean that we should keep injecting ourselves with 6 lakh units of vitamin D? As so well explained by Dr. Agnivesh Tikku, that's a dangerous situation. Even that paper which came from Ambrish Mittal and team spoke about 3 lakh international units, which caused a sustained level longer than oral. But there was no way in which they could really titrate it. What are the health risks? Well, the health risks of vitamin D3 toxicity have been mentioned, and it can go anywhere from anorexia to weight loss to polyuria to heart arrhythmias, and at times can cause serious effects of even CA prostate, huge stones, calcification in the blood vessels, calcification in tissues, all this and more. Hence, supplement yourself with good dairy in diet and maybe oral vitamin D. This looks very similar to all of us today. It is that ball with spikes which has kept all of us indoors, and hence there are no take-home messages because we are all sitting at home. In this COVID-19 state today, doctors are urging patients to keep their vitamin D levels at a good value. Why is that so? Because most of us are staying indoors. The exposure to sunlight is very, very limited, and hence we are struggling. Well, there is also some recent evidence or study coming on about the role of vitamin D in COVID. And I'm sure Dr. Salim Patel, who's going to follow me, will tell us more about the same. All I can say today is the extended indications work for there where we have type 1, type 2 diabetes, hypertension, glucose intolerance, and multiple sclerosis. Please understand, vitamin D deficiency also increases the risk of cardiovascular diseases, asthma, and cancer, besides weakening bones. Sun exposure, there is so much written about it. We heard about the arc of zenith as spoken by Dr. Agnivesh Tikku, but there are certain very important aspects. We must understand that it's a process which needs to take place, depends on our skin color, the amount of melanin content in our skin, the time of the day, the length of the day, the cloud cover, the smog, sunscreen that we may be using. All these may affect the vitamin D. Yet, there is research available which states that 5 to 30 minutes of sun exposure between 10 a.m. and 3 p.m., as rightly pointed out by Dr. Agnivesh, when your shadow is smaller than your height, where your shadow is not taller than you, 10 a.m. to 3 p.m., at least twice a week, to the face, arms, legs, and back without sunscreen will give us sufficient vitamin D3. However, a lot of individuals still need, besides this exposure, oral supplementation and good dietary replenishment to keep their vitamin D in the optimal level. What do we need? Yes, besides sunlight, salmon, milk, tuna, eggs, cheese, fortified cereals, as mentioned by Dr. Agnivesh, cod liver oil, trout, salmon, mushrooms, sardines, eggs, liver, tuna, cheese, cheddar cheese, mushrooms, the portabella type, beef, broccoli, carrots, almonds, apples, bananas, brown rice, whole wheat bread, boiled lentils, sunflower seeds roasted, and shelled cooked edamame. All these can help both the vegetarians and the non-vegetarians to be comfortable, continue with their exercise despite their age, build up their muscles and bones as they age, keep a regular check of their bone density, post-menopausal for women and post-60-65 for men. Of course, take oral supplements and keep their vitamin D at an extremely good level. Having said that, the role of calcium and vitamin D is very, very, very critical and crucial in maintenance of bone health. Sunlight, milk and milk products with exercise at all ages, keeping your peak bone mass at a high level and keeping it optimal, especially beginning at the age of 20, 25 and 30 to keep the calcium and your peak bone mass level so that you have no osteomalacia or no tendency to get early osteoporosis is critical, and we need to catch them young to keep a good level of vitamin D3 and calcium. Having said that, if you've done that, you can celebrate your 100th birthday like this lady doing a split. If not, you will be a skeleton at a very young age with broken bones, with no intent physically or mentally to do any activity or add to the productivity. Ladies and gentlemen, I've shared the information I had, tried to crystallize it in the form of knowledge, and with the few years of using this knowledge, I've tried to distill some wisdom. I hope and pray you have faith in vitamin D as much as I do. I strongly believe vitamin D is an essential component of my treatment of all osteoarticular ailments today. For few, it is like a railing on a staircase that they need to hold on to climb up. That's the elderly osteoporotics. And in others, it's a railing which is a protective mechanism, which gives them the confidence to run up the stairs, knowing that they will not accidentally fall. So make a choice, have full assurance in the heart, and overcome all fears with faith in vitamin D. Thank you all for a very, very pleasant and comfortable hearing. Thank you very, very much. Over to you, Dr. Salim.
Yes. Thank you very much, sir. So now to finish the talk, we have now Dr. Salim Patel, who's a senior medical advisor in Zydus. He is going to talk to us about Sunbless 60K. So over to Dr. Salim Patel.
Thank you, Neeraj. Just open the presentation. Yeah. So thank you everyone for the wonderful talk which has happened so far. Excellent oration by Dr. Agnivesh, who's cleared our concepts about vitamin D. And as usual, Ram sir, who I always love to hear. I always be a part of all his lectures which he has given, right from my UG days to PG days. So excellent, sir. Hats off to you for that lovely presentation. So my job is more easy now. As the concepts of vitamin D are absolutely clear now, my job is to tell you why the reason of prescribing a molecule, vitamin D, with a brand called Sunbless. So Sunbless is the brand which we have with us. And today I'll be talking about why we need to use Sunbless. So the current challenges or the unmet needs as of now with various vitamin D3 formulations. As you know, they are in powder form, chewable tablets, there are sachets, granules, so many things of them, and obviously capsules as well. Powder form and the chewable tablets, they have got less bioavailability. Absorption is always the issue. Sachets, many patients don't have good compliance with them. They use it for a good amount of time. They drop out in between. Already patients are loaded with a lot of pill burden. For example, most of the patients in India today are either diabetic or hypertensive. So n number of medications are going on. Plus another supplement in any of these forms adds on to the problem. And obviously, because of multiple dosing, multiple regimens, you have medication errors. But the most important thing, which most of the formulations of vitamin D3 are facing a major challenge, is the poor solubility of the drug in water. As you know, this is a fat-soluble vitamin. So hydrophilic properties should be looked into when you are taking a drug of vitamin D3. So here, what is the uniqueness or what is the important part of Sunbless 60K? It is nothing but the formulation, where we look into the two aspects. One is called as SNEDs, and the other one is the caplic technology, what we are using. So I'm going to talk about SNEDs and caplic technology, where we are absolutely different from the current preparations available today in the market. So this is a lovely article which describes SNEDs. So the full form of SNEDs is Self-Nano-Emulsification Drug Delivery System. So what is this SNEDs? It is nothing but a mixture which composes of an oil, a surfactant, a co-surfactant, and your drug. This combination is emulsified spontaneously to produce a fine oil in water nanoemulsion, having a droplet size less than 250 nanometers, which is when introduced into an aqueous phase under mild gentle agitation. So if you see this diagram, the yellow one is the drug, is your vitamin D. This is the emulsifying molecule, which has got a hydrophilic head and a hydrophobic tail. When this composition is taken into an aqueous form and given a mild gentle agitation, the entire product starts getting nano-emulsified, meaning the thick molecule, the macromolecule, is broken down into nanoparticles. And what you get is an oil in water nano-emulsion, in which you have the oil right down the center, the drug is concentrated in between, and you have the emulsifier, which gives it a more or less a clear, transparent solution. So this is what SNEDs is all about. There are many advantages to SNEDs. As we say, the conventional vitamin D3 supplements have to undergo 3 steps in their metabolism. They have to get dissolved, they have to get emulsified, and finally they have to get absorbed. Sunbless, as you know, because of SNEDs, meaning before the drug is prepared, it is gone through a nano-emulsification process. So then it has got only 2 stages once it is ingested. It has to dissolve and it has to get absorbed. So the advantage is we bypass the emulsification process to give a better enhanced absorption of vitamin D3 in the body. And secondly, there is no need to be dependent on bile acid for emulsification. So absolutely a new generic term in pharmacokinetics and pharmacodynamic action of this drug. So the advantages of SNEDs are we offer pre-emulsified vitamin D3, improve the solubility, the absorption, and the oral bioavailability of the drug. This technology is thermodynamically stable. It protects the drug from the harsh GI environments, reduces the variability effect, including the food effect. SNEDs technology has already been used in n number of antiviral preparations like cyclosporins, ritonavir, and saquinavir. Zydus has been the first company who has used this SNEDs technology for vitamin D3 formulation, and this is what we are laying our forte on. So the best way to prove anything is evidence-based medicine, as we all have heard about it. So certain studies which we have done with comparative leading molecules or leading brands, and this is what we look after the dissolution profile. So our brand versus the conventionally available brands. In the first one, this study is with a 1000 unit tablet, which says that the in-house formulation, that is Sunbless, is having a higher drug dissolution compared to the conventionally available today brand of 1000 units of vitamin D. The same study, again a dissolution profile, but this time with the sachet drug, which is of 60,000 international units. The in-house preparation of ours is having again a higher drug dissolution compared to the sachets. The third one, again, this time with the conventional 60,000 units, which most of the vitamin D3 preparations are available. So our formulation still having a better dissolution profile compared to the conventionally available 60,000 brands of vitamin D3. So these three are different dissolution profiles in which we have done a study and we have documented this study that why Sunbless scores over the other available conventional brands. Coming to thing what Dr. Ramchandra sir said, he spoke about the role of vitamin D in COVID and giving me an opportunity to talk about it. This is an excellent article published in March 2020 recently from the Journal of Clinical Immunology from Dr. Ghazmi and his team. And what does this article say? This article speaks about three nutrients, three important nutrients. One is vitamin D, the other is vitamin C and zinc. So I'm highlighting the importance of vitamin D in COVID-19 scenario today. This study says that vitamin D has got a protective role in prevention of acute respiratory tract infections. The mechanism of action is immunomodulation, either by autophagy or by apoptosis. Then the important highlight of vitamin D to prevent the cytokine storm which is present during the COVID-19 infection. It reduces the viral infection, as Dr. Ramchandra sir rightly said, stimulation of two important chemicals or hormones, you can say defensins and cathelicidins. Both of these chemicals will cause a decrease in the virus replication. However, it also reduces the risk of viral infections by increasing the level of anti-inflammatory cytokines and simultaneously decreasing the concentration of pro-inflammatory cytokines, which can cause pneumonia-like symptoms. So any respiratory tract infection leading like COPDs or even your tuberculosis, any trigger which can lead to infections in the respiratory tract are taken care of vitamin D. Data also says in this study, there was a high mortality rate seen in chronic comorbidities like diabetes, hypertension patients, old age groups, especially with low levels of vitamin D. So this is indeed a global prevalent vitamin D deficiency, which is particularly seen in elderlies. And in this COVID scenario, the recommendation of dosage of vitamin D would be, your goal in COVID-19 should be to raise the vitamin D levels above 40 to 60 nanograms per ml. So the dose which we recommend is 10,000 IU per day of vitamin D for a few weeks and rapidly raising the vitamin D3 levels, after which it is followed by a prophylaxis dose of 5,000 international units per day. especially in patients who are already COVID positive, or as a prophylaxis if you are taking vitamin D in this scenario. So comparing our conventional or the commercial available vitamin D, which is in 60,000 units, the dose regimen would be taking one vitamin D 60,000 unit formulation once a week for say about 12 weeks. And after that, switching over to the same 60,000 twice a month. And as Dr. Agnivesh has already told us, every 3 months we need to check our vitamin D levels, because the effects of hypervitaminosis D is also to be taken into consideration. Coming to the second part, that is the Caplic technology. Now this is unique. Caplic means it's a capsule filled with a liquid. So our SNEDs, that is a self nano emulsification drug delivery system, which is made as a nano emulsifying liquid, is filled up in this capsule. The advantages of this Caplic technology is it is highly effective means of delivering the liquid form of the drug formulation. It is stable in the hot climate, and obviously the acceptance and the palatability of the drug is much better compared to the conventional formulations. So to give a simple take-home message about Sunbless, it would be this is a revolutionary vitamin D3 formulation because it has the SNEDs technology. You're bypassing the bile acid synthesis in your emulsifying process. The Caplic availability, which is convenient, has excellent compliance, and patients have got or have given an excellent feedback when they have been put on this type of a formulation of vitamin D3. It's an immunomodulator in the COVID-19 scenario. The dose what we recommend is one Caplic once a week for 12 weeks. Prophylaxis, taking again the same one Caplic every 15 days, but to monitor your vitamin D3 levels every 3 months is the key in today's scenario as well. So as we say, what our product is, sun blessed. It is blessed by the sun and loved by the water, because this is a preparation of vitamin D3 which gives excellent dissolution in water, has excellent solubility in water, and it is a water loved product. That's why it is loved by water and blessed by sun. So to end my talk, I would always say the most important thing, as we need to know, we are in the COVID-19 scenario still. Slowly we are unlocking ourselves. So we need to maintain the social distancing so that we don't get into this trap once again. And God bless us all with this current scenario, and hopefully we will fight it out. Thank you.
Yeah. Thank you, Salim. So I have few queries.
Yeah.
From everyone. So Agnivesh, you said that calcitrol and alpha calcidol should not be used in a normal patient who has a vitamin D deficiency.
Yes.
So the recommended dose according to you for cholecalciferol cholecalciferol is what is you're recommending, right? According to the research, cholecalciferol is the recommended vitamin D3 for a person whose kidneys are fine.
Yes. Yes.
So if a person is already taking a drug which has got a calcitrol combination like 0.25 milligram microgram calcitrol and calcium and zinc, which is supposedly the most popular. So what is your recommendation for that? When I see him next in my OPD, what should I do with him?
The best would be to advise him to stop the formulation containing that calcitriol. So if he's deficient, you can replenish him with the normal cholecalciferol, which is the non-activated vitamin D. If his kidneys are fine, his body will automatically convert it to the activated form as and when and how much it needs. So the best recommendation would be to advise him to get rid of a formulation, switch to alternate one of the same drugs minus the calcitriol.
And sir, this next query is for you. In spine fractures, a younger patient, not the old osteoporotic fracture, traumatic fractures, RTAs, when we operate, when is the right time to start vitamin D3? And what is the dose will you recommend to start? Do we need to test or we don't need to test in a fracture spine patient?
I'll be very frank with you, Neeraj. All my pre-op patients, for whatever I may be treating them, low back, neck, vitamin D3 comes as a package of your preoperative investigations. Please understand. I do understand it's an expensive tool to investigate. However, patient admitted, it's a part of our hospitalization process that we would do a vitamin D3 level and suitably start correction. Deficiency, insufficiency would be treated differently, as very rightly pointed out and mentioned by Dr. Agnivesh. Our threshold for using oral preparations is the lowest. Threshold for using injectable is now gone to a very, very high level. We do not recommend injectables as far as possible because getting that 3 lakh unit is not very easy and 6 lakh is an overkill and truthfully not necessary. Yes, if you have malabsorption, you have one of those situations, then you may look at a 3 lakh or a 6 lakh. And the thing is, it's less than 5 nanogram per ml. In that situation, it's okay. Otherwise, it's always oral.
And so would you, supposing if your vitamin D3 comes, say, insufficient or deficient pre-operative,
Yeah.
would you start him on pre-operatively or will you give him post-operatively?
Well, it all depends when the report comes. It's got nothing to do with my surgical intervention nor my bone healing. But in the long run, it's got to do a lot with my bone and joint health.
Okay. And Salim, regarding Sunbless 60K, so in a non-COVID scenario, I'm asking COVID, I'm hoping that the COVID will go away by after September. So in a non-COVID scenario, what I have been recommending is that for patients who come to me and who are vitamin D3 deficient or insufficient, I start them on a weekly basis, give them for 8 weeks. And after that, I tell them that you maintain once a month, one capsule, say, supposing if I'm giving Sunbless 60K, so one capsule once a month. And you are recommending that once it should be given once in 15 days in this COVID scenario.
Yeah.
Don't you think that it may cause toxicity if you give so high dose?
See, ideally what I usually do after 3 months of prescribing them a 60,000 unit, I check their vitamin D3 levels immediately. And once I find that they are maintaining within the range of 40 to 70, then I would keep it at once a month. But if I still feel they are borderline around 35, 40, I would recommend it one capsule at least every 15 days to continue. But checking the vitamin D3 levels after the first 3 months is very important. So routinely I have seen that, especially in this COVID scenario, I have seen many people prescribing that when this is the response what we have got from many doctors, that they like to continue prophylaxis with one capsule every 15 days as a prophylaxis.
What about you, sir? Do you give post-operative, tell them to continue once a month or you stop after 8 weeks?
I continue once a month as a maintenance dose and I do exactly what Salim has done, which is I repeat a 3-month check. Then I may not do a 6-month check. I may then do a 9-month or a 1-year check because I know what sort of a maintenance dose I would need to keep them on. So that's the way I go. There's actually a very important point which I would want Agnivesh to sort of answer because it's something that we work together and we are very, very fortunate to have realized and practiced, is that when we use bisphosphonates or denosumab in the osteoporotic patients, we strongly recommend that you give it only to a vitamin D replete patient. Don't give it to a vitamin D3 deplete patient.
Right.
That's a point which Agnivesh mentioned in his presentation, but I think he should speak about why it is so. And it's very, very important because most of us orthopedic surgeons see that osteoporosis, that T-score has gone down, and we immediately start them onto either giving them an injection of denosumab or putting them onto bisphosphonates. It needs a little bit of thinking. And I think Agnivesh is the right person to give us an answer. Agnivesh, could you just tell us?
Yes. So if a patient is having vitamin D deficiency, let's try to understand vitamin D primary role is with calcium metabolism. Now, if there is a patient who is deficient in vitamin D, there is no way the calcium is going to get absorbed from the gut. Now, the only way the blood will maintain calcium is by using PTH to act on osteoclasts and dissolve the bones and push that calcium into the blood. Now, if you give a zoledronate or a bisphosphonate, which blocks that mechanism, then the blood may have a crisis. It's not getting it from the gut. It's not being able to mobilize it from the bones. So off and on, very rarely, not so common, but we see a patient who has been given zoledronate without checking vitamin D. usually 2 weeks to 3 weeks down the line, they start going into the hypoglycemia. And I had one patient who even had a seizure because he was given vitamin D deficiency when his given zolinronate when his vitamin D was less than 5. So that is very essential. And we have to understand that once you start replenishing, it is not going to get replenished in a day. So it's not that you give a arachidol injection and next day you give a zolinronate. So you have to wait for at least a month and then recheck the levels. If they are normal, then you give vitamin D. Then you give the zolinronate. Nothing will get lost by delaying zolinronate or bisphosphonate for a month or 1.5 months. But if you give it in a deficiency, the patient can have acute symptoms, even have a seizure and even serious events also.
Okay, understood. So nowadays, there is a thing that there is a latest combination which has come, which I'm not so sure whether Zydus has that combination. It's got a combination of calcium and high dose, that is 2000 IU of cholecalciferol, that is vitamin D3, and 1500 microgram of methylcobalamin, which is there since almost 1.5 years now. And many companies have started copying that and basically making that. So do you have any experience in prescribing that?
Is this question to me or sir?
Yeah, both of you can answer. Actually, I want to answer.
Yes, sir can answer. I think sir.
Yes.
I have been using these combinations, but more as a maintenance dose, not as a therapeutic dose. So these combinations work well as a maintenance dose. They cannot replace your weekly dose of 60,000 IU where it is needed. So that's the maintenance dose. You can very well combine a maintenance dose of your D3 or B12, whatever else you want to add to it. But as a therapeutic will be with larger doses.
Okay.
So one question.
Yes.
Yeah. Ram sir, I just wanted to ask you one question. As you said about the 6 lakh injection, 6 lakh unit injection. So there's something called as a STOS regime. In my residency days, I had seen that a lot. When a child with rickets comes in, so usually he's given that 6 lakh unit. Either you break the ampule or ask him to drink it, or he's given the injection maybe after every 15 days for the next 3 doses. So don't you think that was a too high dose seen in a patient or in a child of rickets?
Well, retrospectively today, with the papers coming in from the endocrinologists and the studies, it seems to be a very high dose. Right. But please understand, ours is a very, very, economy sensitive treatment country. Are you clear with what I'm saying?
Right, right.
Where the injectable form of a 6 lakh unit dose is so much more less expensive than the lesser products. When I'm saying lesser, as far as the quantity of the basic drug.
Right.
Now I go a step further. What is now done in children, and which I'm sure Agnivesh also practices, is that oral 60,000 IU units are given more regularly, rather than weekly. Am I right, Agnivesh? You have been practicing that. Am I right on that?
Yes, sir. We have been using oral. We can even give it daily also.
Yes.
For smaller children, we prefer to give half dose. We give 30,000 international units. You can give it daily for 3 days, 4 days, as you have decided for the thing. But probably it's more safer and more physiological.
Yeah.
Right. Okay.
So what about one more question regarding this now daily usage? What about in adults? Say supposing you get a vitamin D3 dose of around 10. And we know that this patient is a non-compliant patient. So instead of Sunbless 60, it comes in 8 packs or 4 pack?
4. It comes in 4.
So what about you take once a day and finish off your whole 2 weeks dose in 8 days, and then after that you continue it once a month. Have you anybody tried that?
I'm one of those who has breakfast, lunch and dinner. I don't have all 3 meals in the morning.
See, actually what we do, Neeraj, we have this pack of 4, but we give it in a box of 2. So in one box, you got 8 doses coming in. So it is 2 by 4. So ideally what happens when this pack is made, we generally have a labeling put in there, this has to be taken once a week only, because there are some patients who may consume, maybe 1 or 2. They may, we have seen that some patients have taken it even twice a day for a few days, and they have come back with some problems. So that's why the packing has now become in such a way that you get a strip of 4 only, maybe in a box of 2, but clearly mentioned on that. You have to take it as once a week dose.
Once a week, okay.
Because there was a very important point which Agnivesh had brought out during his presentation. which is that when you're taking oral vitamin D3, your chances of causing a hypervitaminosis is low.
Is low. Right.
It's a very important point he brought out, and he told us also about a patient. Am I right, Agnivesh?
Yes, sir. It's that even 10,000 taken daily has been rarely translated into a toxicity.
Yes.
So even a patient continues to take weekly, it's very rare to see that they land into toxicity of 150 or more than like that numbers. But with an injection, you have seen patients, a single injection can trigger them off to a toxicity.
Right.
Okay. So I am done with my questions. Thank you very much. We thank Dr. Agnivesh, Dr. Ram Chadda and Dr. Salim Patel for this excellent presentation on vitamin D3. And we thank Zydus, the makers of Sunbless 60K, Nucoxia, Decadurabolin, and OCID QRS for this webinar. Thank you and good night.
Thank you.
Thank you very much.
Thank you.
Thank you.